One of the things that I actually love about my job is that we see absolutely everything. Really, every pathology is going to touch through radiology at some point.
I'm Radiology. I'm the PA hosting eShadowing, as you all know. And today our guest is Angela Nash. Hi, Angela.
Hey, how are you doing?
I'm good. How are you?
Doing great.
Good. So Angela is actually in interventional radiology, which is I'm very excited for because not many PAs are in this specialty. So I have a lot of questions for Angela, and I'm sure you all probably do too. So I'm going to first start off by introducing her or giving a short bio. Angela has been a PA for over 12 years. She did her undergrad at University of North Carolina?
Yeah, North Carolina State University.
North Carolina State, yes. And then she got her master's at Shenandoah, and then went to get her doctorate at MUSC, right?
Yeah.
And she's done over 10 years in interventional radiology and 2 years in pain management. So thank you, Angela, for coming on. We're so grateful to have you and can't wait to learn from your expertise.
Excellent. Thank you for having me.
No problem. So can you tell us about interventional radiology and actually first how you got to the PA career and then interventional radiology?
Yeah, sure. So for my undergrad, I actually originally wanted to be a pediatrician, which I will tell you would be probably the last career that I would do now that I'm practicing. But at the time, I thought that I wanted to work with little kids. And then I realized that they don't particularly like you very much when you're in there taking care of them. They usually hate you and cry, and it's not as a wonderful experience as I was expecting. So I met with a family friend who is a PA, but her brother and both her parents were doctors. And she was non-biased. She gave me both sides, and she just said, these are kind of the pros and cons of both fields. And she basically kind of swayed me with the flexibility of being a PA, kind of the work-life balance. When I was looking in PA school, PAs didn't really work a lot of weekends or call, which is changing now. But at the time, it was very appealing to be able to have a family, be able to have that work-life balance, be able to put food on the table, support yourself, have all the means that you need, but also have a life on the outside, and also be able to switch specialties, which I've actually stayed in the same specialty, but in general, it is PAs usually switch and have throughout their career to different specialties. And we have a lot of people that come from surgery and stuff, and those skill sets can translate into other fields.
Right. Okay. So what about interventional radiology? Because that's such an interesting specialty, and I feel like it's highly skilled and specialized. You have to know specifically so much just for that and all the procedures you have to know and do. Can you tell us how you decided or why you decided to get into that specialty?
Sure. I will tell you it's partially by luck because I did not know much about interventional radiology. It's not one of your skill sets that you're taught in school. And I recommend that if you guys go to PA school, that during PA school and after you get involved in your local chapters, because I went to a monthly meeting with a local chapter, and one of my fellow PAs stood up and said, "Hey, we're hiring an interventional radiology." And so I was like, well, that's interesting. I'm going to go check that out. And I will tell you that we usually do not allow for new grads. Because we do want people to have experience. However, I was a new grad, and I basically went in and was like, I really want this job and I'm willing to learn. And so I got really lucky, and right out of school, got a job in interventional radiology. Originally, my practice up in DC that I worked with, we worked more with clinical. But in general, I'll speak to more so what I do now. Which is I do diagnostic and interventional radiology. And what that means is from an interventional standpoint, I am very autonomous. I do my own procedures. I do really a whole selection of stuff. And I only really work with my attending physicians when I'm in the clinic. So my day-to-day for the interventional part would be doing venous access, so getting lines for people who have to go on dialysis, or getting IV access for doing biopsies. So if someone was to come in with a liver mass or a thyroid mass or anything like that, I would use ultrasound. So really what interventional radiology is using image-guided tools. So real-time x-ray, which is like fluoroscopy, which is real-time x-ray, ultrasound, CT, so using a CT scanner real-time. So I wear lead during anything that's using x-ray. So CT uses radiation, fluoroscopy uses radiation, and I have literally a lead outfit that I wear to protect myself. Since radiation is cumulative, so I'm around it all the time. And then for my diagnostic procedures in North Carolina, it varies from state to state, but in North Carolina, PAs are allowed to use fluoroscopy. And so I do studies on patients like barium swallows, upper GI. So if someone came in and they were having reflux, or they were having a small bowel obstruction or something like that, and that you didn't want to radiate them with a CT, there's a lot of answers that you can get with kind of more less invasive, less expensive studies, and we start with those. So I do those and that. And then I also cover actually adult and peds. So we're attached to a pediatric hospital. So I cover both fields.
Wow.
Yeah.
That's amazing that you're learning and knowing the adult anatomy and kids. So, and especially for radiology. My next question is, how were you able to master reading X-rays, CTs? What books do you recommend for when we get to PA school? What did you do to get all that down? Because I mean, X-rays are fine, but getting CTs, I'm just like, what am I looking at? Like, we rely on radiologists so much.
Yes, you do. I will tell you that the key to really anything as far as any diagnostic stuff is seeing what is normal. So really getting in there and doing a lot of, books are only going to do so much, but if you could ever get in where you're at, which is extremely boring to watch diagnostic radiologists do their thing, but it is going to be very helpful because everything's in 3-dimension. And so learning, what are they looking at? How does the anatomy, learning your anatomy is very, very, very important for interventional radiology. That is a must through PA school. Get your netters out, get your, and look at your anatomy, make sure that you understand where vasculature is, where the organs are, and all that stuff, because that really can help you break down pathologies and, as we'll talk about later, potential side effects to a procedure that you may cause. But if you know what arteries are around, what vessels are around, what organs, all those things, what are my potential blocks that I may or may not hit when I'm using a needle? And those are important.
Okay. And Angela, what are some common cases or patients that you see, like patient population that you see, or diseases?
Yeah. So one of the things that I actually love about my job is that we see absolutely everything. Really, every pathology is going to touch through radiology at some point. As far as doing procedures and stuff, on the majority of the day, I'm really seeing a lot of GI patients for the diagnostic aspect. As far as outpatient, inpatient, we're doing a lot of studies where we're checking people post-surgical. So if they had a surgery where they had cancer and they had to have some of their stomach removed, then they would come and do a study with us where I would give them some contrast and make sure that the stomach lining or the surgical lining, which is the anastomosis, where the two pieces have come back together, to make sure that there's not a hole in that area and that there's no contrast leaking out, to make sure that that area is healing. And then as far as doing the IR stuff, tell me your question again. I'm sorry.
It's okay. What was I saying? I asked about,
I did this to you. I'm sorry.
It's okay. It's okay.
I remember now. Talking about the different pathologies. Yeah.
Oh, yeah. Yes. So, yeah, the most common diseases or the patient population that you typically see.
Right. And then as far as for the IR stuff, we see everybody. So kidney patients, we put nephrostomy tubes in. So if you've ever heard of someone having a kidney stone, if they can't pass it, we'll put a tube in their kidney so that urine can be used as an outlet. Since urine can't get down the ureter into the bladder, we give them something alternative to buy them time to surgery, something like that. We see a lot in our clinic patients with PAD, which is what we'll talk later, and that's peripheral arterial disease. So people who smoke, have high blood pressure, high cholesterol, they're literally north into the whole Southeast. We have a lot of people there that still come in and they have claudication, which means when they walk, they have pain in their legs, and that's from not having good blood supply to their legs. And sometimes you hear about diabetes or peripheral neuropathy, and they can get sores on their foot. And what happens is we see a lot of them because they have a sore on their foot, and then they need us to open up and use a balloon or a stent to open up the blood flow to their feet. So really a lot of vascular stuff, a lot, we're a profession of tubes. We put a lot of tubes everywhere, tubes in your neck, tubes in your vein, tubes in your artery. So lots of catheter work for the IR side of things.
Okay. Do you also work with the vascular surgeon or interventional cardiologist?
So really that varies depending on the practice that you're with. In my first IR job, we had basically a sister relationship with the cardiac team. And so the cardiac cath lab was almost connected to our interventional suite. But here in Charlotte, there really is it's not a competition per se, but they do provide some similar services to us. And you will find that throughout your career that there are different lines of professions that they sometimes do the same procedures. And it's not necessarily that one way is better than the other, although for each profession, we always make the argument that our way is better. But we don't per se really work with them. The only time that we work with vascular surgery now is if it's something that actually needs like a surgical bypass, something that can't be done with a minimally invasive, which is by definition what interventional radiology is doing minimally invasive work, or something that is so small that they don't have the tools to be able to handle something in the smaller vessels, say below the knee.
Okay, thank you for that. Mm-hmm. So just going to answer some of their questions before we go into the case study, and then we'll answer any remaining questions after. Okay. So someone asked, how has COVID affected your practice? Because I know early on, a lot of hospitals, including the one I worked at, they were just doing, they stopped all elective surgeries and procedures. So how is it now?
That's a great question. Back in March, when all of this was really new, we did stop all of our elective procedures. So currently I am 95% in the hospital. I also worked and did treated veins in our vein and vascular clinic. And those procedures definitely were put to a halt because they were not, it's not an emergency to get your veins treated. Right. But in the hospital, if there had to be an urgent or emergent indication for those procedures, and really what we're looking at here is just exposure time, exposure to the staff, exposure to the person performing the procedure. And also what we're looking at is something called, is it aerosolizing? So some of the procedures that we do are not considered an aerosolizing procedure, like doing something like a lumbar puncture on a patient, because they're not really doing any increased breathing. But I'm sure that you've heard that one of the things that people are having from COVID is strokes, and our team is part of the stroke team. So we go in and use a catheter, again, a tube that goes up to the brain and can roto-rooter and suck out the clot, or use a blood thinner to break down the clot to try to preserve brain function. But in order to do that, we need them to be asleep. So they're intubated. So as far as our stroke was concerned, those did not change because those are emergent cases. But anything that was elective, we really tried to keep that down. We very quickly found that we weren't getting hit like New York or Detroit or Chicago or Portland or any of those places where we had. So we were able to open up our elective procedures or open up our oncology cases. We see a lot of oncology patients here. We are part of a big oncology renowned practice that is connected to our hospital. So we see a lot of stem cell transplant patients, and they need those treatments. And everything in medicine, everything in life you will find, including COVID, that, but especially with medicine, is that life is about risk and benefit. And is the risk of the procedure higher than the risk of not having it? And in a lot of those cases, the risk of putting a mask or an N95 on an oncology patient so that they can get their cancer treatment outweighs the risk that they're going to get COVID. So we have really returned back to baseline, I would say, from maybe June or July until maybe in the last month. And then in the last month, we had about maybe 10 COVID patients on our procedure schedule today. So now we're ramping up, and we're seeing more, so that instead of less cases, we're actually seeing more, just because we're seeing more COVID cases.
Okay. Wow. Okay. So, say they come in, of course, like a possible stroke patient. What do you guys do as far as testing? You have to, of course, treat right away and then wait for the confirmed results, I'm guessing, right?
Exactly. Okay. So they're automatically tested when they come in. All stroke patients are automatically tested.
Okay. Yeah.
And then anybody for an elective procedure, they have to be tested within 5 days before they're allowed to come in.
Okay.
And have the results back. If not, then they are rescheduled. And then for patients that are in the hospital, if they now we are differentiating between symptomatic and asymptomatic. So if they are symptomatic and we don't have their test results, then we would ask, is this an emergent or urgent case? And if not, then we would wait the 24 hours to get their results. If they're asymptomatic and they need it, same thing. If it's more of an urgent situation, then we'll just gown up and, I wear 2 masks, an N95, a regular mask. I wear something over my head, booties, and then 2 gowns.
Okay, wow.
It's very hot in there.
Oh yeah. But what you're doing is amazing. Like, you do so many procedures. So for everyone interested in going to PA school, like, if you like doing procedures, it sounds like interventional radiology is the specialty to do.
Yes, definitely. And we do take students. So, we are starting to take students again now. I was telling her earlier that we have to basically sign a waiver now saying that you recognize that you're coming into a COVID positive situation. We are a level 1 trauma center, and we do have a lot of COVID patients, but we do take students. It's a great job because you do get your hand in basically every pathology, and you kind of know if needles are your thing.
Right. And Angela's in North Carolina. Do you mind providing your email or contact information if they do have questions?
Yes, I would love to.
Okay, I'll write it in the comments.
Okay, sounds good.
You want me to put your email?
Yeah, you can put my email.
Okay, I'll get your email and type in the comments. So just to answer a few more questions, someone wanted to know, are you worried that computers will take over the radiology career?
That is a really good question. So I will tell you that a study came out a couple of years ago, that artificial intelligence study about reading x-rays. And they gave them about 4 to 5 hours to read x-rays. And in that time, the radiologist read about 400 to 500 chest x-rays. And the computer did it in about 4 minutes. And so it's pretty terrifying as far as job security goes. However, there is something to be said, and what they found is that even though it could read it with fairly close specificity between both groups, that actually it didn't really matter whether it could go faster, that people want, as you said, you look to radiologists all the time. They want the ability to have somebody that can provide the clinical background with what's going on, and they want to be able to have that interaction with somebody. So although it can push out a lot, chest x-rays a lot faster, I don't think that we're quite there as far as pushing it off, but I will tell you it is being tested, and if I would be lying if I didn't say I saw it in the future, at some point.
Yeah, call me old school, but I would not do it on a computer to diagnose anything. I'm sorry. I can't. Like, I need the human eyes looking at it. We can confirm it with a computer, but computers make errors. I need somebody who knows, who had that education, who understands, who has the clinical background, like you said. I don't know. I wouldn't do it. But
well, and a lot of times the computer just tells you a description. So they'll say, I see a hypoechoic linear or circular mass within segment 2. It's going to read like a stereo instruction book, like we all used to read way back in the day. And so it's not going to give you these are characteristics of this, or I've compared it to this, and this person has this type of cancer, and this doesn't look like that type of cancer. It's just going to give you descriptions. And so I think there is that component there. Also, the good component as far as interventional radiology is we're not going to see that because you actually need a person to run those procedures, not necessarily just reading a study online or on the system.
Yeah. So I feel like computer would be good for assisting in reading and getting a better or clearer idea of what it could be. But I wouldn't just completely rely on a computer. And I hope it never turns out that way.
Me too. I do too. I don't think that it would be the right route. I think it would definitely be detrimental to the patient.
Exactly. So one more question before we get to the case studies. Someone wanted to know, what is your schedule like, I guess, as far as your work hours, if you're on call at all?
Sure. I have a great schedule. I work maybe 1 to 2 weekends a year currently. Yeah, so it's not bad at all. I do not take call. I work different shifts, 7 to, and I will tell y'all this is not normal, but I work either 7 to 3:30, 7:30 to 4, 8 to 4:30, or 8:30 to 5. So also not a usual schedule for PAs that are hospital based. Now, when I am 5 o'clock, I usually do end up staying a little later. I either have nothing after 3 or I end up staying late because you do want to stay until the work's done. But another beauty of being a PA and also being in interventional radiology is very rarely are things an absolute emergency that you need to like run up and do that in my current role.
Okay, wow. That's awesome. So it's been so good so far. So we're going to get into the case studies. So you all know how it works. We're going to have, if you want to get on the case or on the video, then to raise your hand and I'll select you. I usually just go by whoever raises their hand first or whoever I see first. And you have like holidays off as well?
Yeah. So we all rotate. So we are a very large practice. We have over 100 radiologists and we have 28 PAs. But we have 26 PAs and 2 NPs. So we all rotate throughout that. So I'll usually work a holiday about every 2 to 3 years.
Oh, wow. That's so great.
Yeah. So it's, and then, and even when we have to cover, as we're growing, more and more people. So then, but maybe it'll be a holiday a year or not even. So it's great. The only holiday that we don't cover in the hospital is Christmas. Everybody gets that off.
Oh my gosh. That's awesome. You have such great work-life balance. Like,
yes.
Your schedule is amazing. Holidays, weekends.
Yeah. Yes.
All right. So Ryan, can you hear us? I see that you're on the session, but I don't see your video. Okay, there.
I think I got it.
I'm sorry, Ryan. I'm sorry. Ryan, how are you?
Good. How are you?
Good. Okay. You're a little frozen. Is it okay? Can you see us?
Yeah.
Okay, now it's better. Okay. Hi. So we're going to go through some case studies, or one case study with you, okay?
Okay.
All right. You can take it away, Angela.
Okay. So this is going to be a typical patient that we would see in our clinic. So the first one would be this patient comes in maybe from a referral, either from a primary care or an urgent care, or usually actually a wound clinic before they get to us. And they're going to come in, and this patient, the basic stuff that you're going to know is that they have a wound on their foot, on one of their toes, that they have high blood pressure, that they have high cholesterol, and they have diabetes. So what are some things that you're possibly thinking?
What
are some things that you would ask them?
Probably just like how their diabetes has been, like if they've had like any trouble, or if they've noticed that it's kind of been like off the charts, and that if like they're keeping their diabetes under control, because that like has a lot to do with like the wound, because if their diabetes is out of control, they're more than likely not gaining like the blood pressure and blood circulation that they need to like feel their like that the wound is there.
Yep, that's exactly right. And so that's perfect. And do you know how we check to see what their blood sugars have been?
The glucose test.
Yeah, so a glucose test is a way to do it. And then one of the ways that we can see what it's been over a longer period of time is doing a hemoglobin A1c. And so that actually will tell us over a longer period, and it should be 6 or less. And unfortunately, a lot of these people, you're going to test it, and then it's going to be like 13 or something.
Oh my gosh.
Yeah.
That's a lot.
So, okay. And what's something else that may happen that these people would also get ulcers from?
Smoking.
That's right.
Smoking. Okay.
Yes. So actually, the same as with diabetes. Diabetes causes constriction of the vessels, especially in the microvessels. So the really, really small ones that feed your digits. And but nicotine actually causes vasoconstriction. And so if you think about this, if your vessels are doing this all the time, eventually they're going to get tired of doing that, and they're going to start to slow down. So your tube, just like an artery, it comes. And so then all of a sudden you don't have blood flow to your foot. And if you think about if you cut your finger and it bleeds, that's part of the healing process. But if you have no blood there because it's cut off, well, then it just turns into this really gross black thing and then like dies.
Yeah. Yikes.
So can you think of anything that you may studies, or what would you do if you saw this? Do you know things that you would look at on the physical exam to maybe check it out and see?
Maybe just like their viral load to determine like if the wound that they have is like infected, or how infected it is, and like if it's causing like other issues with their health.
Yeah, that's a really good answer. So culturing it to make sure, I would also, a couple of studies that I would probably recommend are one, maybe an MRI to see if they have osteomyelitis. So the infection can start and then it can actually track into the bone. And then sometimes they need to be either on long-term IV antibiotics, or sometimes they actually need an amputation. And then also a study called arterial duplex, and that's with ultrasound. And what they'll do is they'll ultrasound the vessels that are leading to the foot, and also check the blood pressure you were talking about. Does the pressure get there, to make sure that where exactly is the blood flow stopping? Is it
going?
Yep, exactly. What about physical exam? What exam would you do to the patient?
You could do like the diabetes exam, like with the little like the brush like on their foot, or like I don't know really what other exams like you do for people who have diabetes, but I feel like that's probably like one of the main ones to determine like how much pressure they can feel.
Yeah, I think that's great. Basically, just putting your hand on the patient is really important. Is their foot cold? So if their foot's cold, then they're not getting good blood flow there. What does their pulse feel like? You know, you're always feeling your neck, you're feeling your wrist. You should be able to feel people's pulses on their feet. Listening to their heart. You know, if they have bad disease in their legs from smoking and diabetes, they could also have something in their neck or in their carotid artery. Every so often, they come in because they're complaining that their legs hurt, and then we listen to their neck and we can hear that they have a brewery, which is like a shoosh, shoosh. And that means that instead of it being open, it's kind of like sticking your thumb over a
closed.
Yeah, exactly. Like sticking your thumb over a hose. And so it makes that brushing sound. And then, you know, so looking at all those things, listening to their heart, make sure you don't hear a murmur, make sure they haven't had chest pain, all that stuff.
Do a lot of people that you see like with diabetes, are they also smokers, or it kind of just varies?
Well, I live in North Carolina, so yes, but a lot of people in North Carolina still smoke, and we're or now vaping, and remember it's the nicotine that we're really seeing the issues with, but yes, they do smoke, or they have a history of smoking. You have to think that a lot of the people that are coming in now, the people that you're going to see that are in their 50s, 60s, 70s, even 80s, smoking was not abnormal when they were younger. So they may not currently be smoking, but they smoked previously. And so now we're getting the ramifications of that.
Gotcha.
Yeah, this is all great. See, you're going to save this person's leg.
That's cool.
Yeah. So basically the next step would be is if you went in and you couldn't feel pulses and the ultrasound showed that things weren't, that they didn't have good blood flow, we would take them to an angio suite. We would, one of the interventional radiologists would go in with a catheter, and then you hear just like people get in the chest where they get an angioplasty or get a stent when they have a heart attack. It's the exact same. They get that in their leg, and they basically use a balloon and try to open up that blood flow. And it's very successful. And sometimes you think someone's going to lose their foot, and just by opening the blood flow, it can turn that around and everything can heal.
That's so good too, because like I would never just want to like go straight to being like, okay, you need an amputation, like because that's so devastating.
Absolutely. And think about it, even if they do need an amputation, you need blood flow to heal. So sometimes it's been too long since they got to us, so we know that they're going to go in for an amputation, but we'll go ahead and treat them so that their stump from where they had their amputation will heal.
Have you ever like seen or done like an amputation where like the blood flow isn't restored at all, or is it normally always restored? Sure.
So you would always do the amputation where there is blood flow. So, so that means that if someone's toes were dying, which sometimes happens, then you would cut here or cut up, it's called a BKA, or below the knee. And if they had something that was ulcerating up, then, or if the osteomyelitis was continuing to track up their leg, then you may have to do it above the knee. And I will tell you that very cool. When I was in school, I did orthopedic trauma, and doing an amputation is really cool.
Oh my gosh, I bet. Yeah, it's like you see it on Grey's Anatomy, but it's not the same.
Yeah, it's probably a little different, but it's still pretty cool. So that's great. That was that's exactly kind of straightforward. You just got to open up the tubes.
Okay, got it. That's awesome, Ryan. You did so good. Like you're pre-PA still or in PA school?
No, I'm pre-PA. And this is like my first like eShadowing experience too. So I was kind of scared. I was like, oh gosh, what happened?
Oh, you did wonderful. That was fantastic.
Good job.
you.
You're going to do so good in PA school.
Oh, thank you. I hope so.
Yes, that was wonderful. Nice job, Ryan.
Thank you.
Do you have any other questions for Angela?
I don't think so. So what hospital do you work at?
So I don't work I'm employed by a private practice. So I'm employed by Charlotte Radiology, but I contract in with a hospital system, Atrium Healthcare. And so I cover 6 hospitals.
Okay. So do you like the hospital atmosphere, or do you prefer like the clinic atmosphere?
I love the hospital atmosphere, and I tend to like the trauma center. I have a personality where I like the harder cases. I like things to be a little quicker pace. I like to be very busy, and I want to do the cases that are more difficult. And so that is a good atmosphere for me. But it's also nice to go to the smaller facilities and have a break.
Yeah.
Too.
Yeah, I bet. Yeah, I'm really interested in emergency medicine too. I just like hearing like different people's opinions on whether like they prefer a hospital atmosphere or a clinic atmosphere, because a lot of like PAs now say that you're more like on your own, I guess, in a clinic atmosphere than a hospital atmosphere, because there's certain like rules and regulations that the doctor has to like oversee a PA like in a hospital atmosphere, I guess. So like a lot of, I guess, just like I've heard that a lot of PAs like that want to be more independent of a doctor prefer the clinic atmosphere, and then like vice versa. So I always just wonder, like.
Sure. I am like I said, like 99% hospital based, and I'm very autonomous. So it really all depends on the practice that you work for, the hospital privileges that you have. I'm sure that also varies state to state in what rights that you have, which is also really important to be involved in your local chapters so that you can give them support to go to Congress to get more rights for you. But in general, also really being on top of your game and being knowledgeable and being the best will allow your attendings and referrals, whether they be MD, MP, PAs, to have trust in your judgment, and you will gain autonomy by being that person. One of my attending physicians, it was one of the best things that I learned very early. One of the procedures that I do is called a thoracentesis, and that's where I drain fluid from around the lung. And a punctured lung, or a lung that doesn't re-expand, happens in about 2 to 4% of patients. And he told me very early, he said, if I was to get a pneumothorax after the procedure, someone would say, well, it happens 2 to 4% of the time. But if you get a pneumothorax, cause a pneumothorax after a procedure, they're going to say it's because a PA did it. So you have to be the best of the best in order for people to know that it's not you or your profession, it's just the source of the game. And that's why it's important to do the best you can. But it sounds like, I mean, you're doing really good and you haven't even gotten there yet. So I think you're going to do just wonderful.
Thank you. I hope. I think that's all my questions.
Thank you. Good luck.
Thank you so much.
Thank you. All right.
Thank you, Ryan. Have a good night.
You too.
All right. Good night. Okay. All righty. Thank you for answering that, Angela. I definitely agree. I think that the PA specialty as a whole, even though it's still fairly new compared to like, nursing or being a nurse practitioner, I think we're pretty autonomous. Even me working in the ER, I work in the ER, Ryan, and I work very independently, and I really go to the attending if I have a question.
Yeah, that's me too. I mean, and we have a relationship. We see each other all the time. It's not it's not that we don't like talking to each other. It's just that we really don't need each other.
Right, exactly. All righty. So we have time for one more case study, and it looks like Tamia raised her hand. So we're going to do one more case study and answer any questions, a few more questions, and we should be done wrapping it up.
Okay, sounds great.
Thank you.
I can tell you guys are already emailing me. I promise I will get to you.
Thank you so much for being so kind. They ask the best questions and they're so eager.
Yeah, no, it's no problem at all. I promise if I don't get to you within the night, I will get to you. I promise.
Thank you. All right. So we have Tamia. Tamia, can you hear us? Let's see if Tamia can come back on, or we might have to take someone else. Let's see if she'll be able to come back on. But let me see. There was another question. Ikra wants to know how late is too late in order to get a wound check, which puts you at risk for an amputation. Does it vary patient to patient and patient compliance? This is a question.
Okay, so that's a great question. I will tell you that it's a long time. So unfortunately, some of these people have a wound on their foot for months, sometimes even a year, that they just kind of cover up with the sock and don't really worry about it. And so very, very rarely will you see a situation in which a wound is emergent, meaning that something happened. They stepped on a piece of glass and then all of a sudden they need to go to the ER, or they're going to lose their toe. It doesn't work that way. So they have plenty of time to get in if they were to get evaluated, to be evaluated by you, to get it cleaned up, get these things, and then they would be, and then not necessarily coming to us first. I think going to wound care first, a wound care clinic would be appropriate. And then if they find that they aren't getting good blood supply or not being able to heal the wound, then they can send it to us. But the only time that really you would ever have an emergent situation, and wouldn't necessarily be an emergent amputation, but would be if a foot turned acutely cold, meaning it was warm and then all of a sudden it's starting to turn dusky gray or black, and you're actively watching that happen. And that means that there has been an acute clot in the artery, and that is an emergency. And so that's not necessarily a wound, but that's something where we would go in and we would use blood thinner or something called a lysis, where we would go in and try to clean out the artery. That is uncommon. Most of the time, this is a chronic, slow process where they've slowly had poor blood flow, and then they've needed intervention. Or actually, if they don't have a wound, you can actually put them on a walking program, and they will actually they will build collaterals to make up for that blood flow. If it's just claudication. So that's an option as well.
Okay.
Yeah, good question.
Thank you for that. Okay, so we'll try to see if Tamia can come back in, if she can raise her hand or join the video. If she's not able to, then if anyone else wants to come on to do the last case study.
My question was, what advice would you have to pre-PA students who are discouraged about going into medical school? Because, in college, you're surrounded by a lot of your peers and a lot of other people who are mainly competitive, like they have high GPAs, they might not think they're competitive enough. And I was just asking, what advice would you give to somebody who was feeling discouraged?
So I would tell you that you never know until you try. So, but it is really important. I'm on a lot of forums, and I see that a lot, that people post that they have a really low GPA, or and they're trying to get in. What I would focus on is why do you have a low GPA, and what do you need to do to make your GPA higher? If you have a higher GPA, you're going to have that confidence. So what classes do you need to take to make sure that you're prepared to be able to go to PA school? Because I will tell you that my undergrad was in biochem, and it didn't hold a candle to how hard PA school was. PA school is a lot of work, and So it's important that not to get discouraged, but be prepared. And I think that'll follow you for the rest of through PA school and your career, that if you are prepared and then you will be more confident. So if you study hard and you know what you need to do, then when you'll be more prepared when you go in to apply, to say, look, I didn't do well in this class. And so you'll see that on my transcript. But then I went and I took this class and I aced it. And I did that to make sure that I bettered myself and learned from those. And I think that's what people are really looking for. If you didn't succeed at this, what are you doing to make it better after that?
You believe it's, well, I guess it differs, but I was going to ask, do you believe it's better to be more rounded in GPA or your extracurriculars, or are they a unit?
Oh, that's our question. I really think it's probably part of the program. I will tell you that when I was looking into PA schools, they one of the presidents of the school said that it was only GPA, and that they were not, it didn't matter any extracurricular activities that you had, that they were only looking at GPA. However, I will tell you that these days, if there's 10 of you or 20 of you that all have good GPAs, those extracurricular is going to matter. They're looking for someone to stand out. And so the more that you do, and the more medical experience you have, and I really do think that it's important when you're in school, getting a job, not just shadowing, but getting some clinical hours is really important. Whether your school requires it or not, the schools that you're looking at, get those hours so that they know that you're dedicated to, and that you can balance being in school and getting hours, and that they know that this is what you want.
All right. Okay. I think people in the chat are asking how low is the GPA.
Excuse me?
I was reading in the chat and they were asking what is considered a low GPA. Sorry, I was reading out loud. I didn't realize.
No problem. Yeah, I think every school, there's an average GPA, but I think it kind of depends on the schools. And then the AAPA actually releases a profile every year of like the typical or average PA scores or PA student scores that get into PA school. So you can go on aapa.org to read about all that. It releases like their GRE scores, average GPA, healthcare experience hours that they've had, community service hours. So that gives you an idea of, what you need to have to be competitive.
Okay.
Okay. Did you want to go over a case study with Angela?
I'll let somebody else do that because I see we're running out of time.
Yeah, okay. All right. Thank you, Tamia.
You're welcome.
Okay. All right, bye-bye. All right. Well, Angela, it's almost 8:00. Would you have time to do one more case study, or do you have to go? Or
Oh yeah, no, whatever you would like to do is fine.
Okay. Does anyone want to do a case study? If you want to get on to do the case study, then okay. It looks like somebody requested. All right. We have Canty. Okay, so we're just doing this one more case study. We won't have time to answer any more questions after this, but if you have any questions for myself or for Angela, I did provide both of our emails and my social media handle. This was great. Thank you again, Angela. They really like you and all your knowledge. So
good. I'm glad. Anytime.
Thank you. Okay, so we're just waiting for Canty to come on. Yeah, somebody said something about scribing. A lot of schools don't want scribes. I don't understand why, because I think scribes are amazing and you see so much and you learn how to document and everything. Mm-hmm. So I would definitely count it as patient care experience, but a lot of schools want like hands-on experience. But
yeah, they want you touching the patient, being actively participating in their care.
Yeah, but you definitely learn a lot as a scribe. You learn and you see a lot.
Mm-hmm. Don't read my notes.
But you don't have a scribe, right, Angela?
No, we do everything through EMRs now.
Okay. Yeah, good patient care is anything like we said where you're directly touching, interacting with the patient. So EMT, MA, CNA, yes, those are all good. Okay, so we got Venetia.
Hello.
Hi, how are you?
Good. How are you? Wow, I can't believe I was picked. I'm so excited.
No problem. Your video is off, or at least I don't see it.
Let me.
There
Okay.
you go. Yeah.
Hello.
Hi.
Is it Venetia or
Vanessa.
Vanessa? Okay, thank you. All righty, nice to have you.
Thanks for having me.
Of course. So we're gonna let Angela walk you through the case study, okay?
Okay.
So the next case study that we're going to do is actually going to be about procedure based. So I'm doing a bone marrow biopsy on a patient with leukemia. And so before I even do the procedure, what are some things that you think that you would look at in the history?
Okay. I actually had one of these done.
Okay.
But I actually don't know what I would ask for the history.
No problem. So really, do you remember some things that people asked you? Like, why are you here today?
Yeah.
Have you had this before? If you did have it before, did you have any problems with it? Exactly why are we doing this? Because we want to make sure there are times when we get orders for procedures and maybe what they've ordered or what they think we should do is not necessarily actually what they need. So you always want to know, and this goes, guys, for anything in medicine, you always want to know why you're doing what you're doing. And if you can't explain that, then if something goes wrong, you're going to be in big trouble with the lawyers because they're going to be, why did you do that? And they don't accept, I'm not particularly sure. They just told me to. So you need to always know kind of why. So in this case, the patient, say, had leukemia. So if you remember, was there some things that they had you do before to get checked out before you had the procedure?
Like after the procedure was done or before the procedure?
Before
the procedure, they did ask me a lot of questions. They took my blood pressure, a temperature, like normal vitals.
Did they check any labs?
They did. They did a CBC, and I think a CMP too, actually. But yeah.
So one of the things that we do with almost all of our procedures is always check labs. So you want to make sure, especially in patients that are going for any procedure, but a lot of times with bone marrows, especially when they have a blood cancer, that their platelets are low. And a normal range would be somewhere around 100,000, 115,000 to 400,000. And some of these patients, their platelets are closer to 10,000. And if they're below 10,000, then we transfuse them before this procedure to make sure that they don't bleed. Definitely looking at labs, looking at platelets, looking at asking simple questions like, are you on any medications? People are on medications that make their blood thin, or does that put them at risk for bleeding during the procedure? And then as far as the procedure, you're a perfect person for this example. Did you have your bone marrow biopsy in the office, or did they use image guidance?
In the office.
Okay.
I laid down on the bed, obviously on my stomach, and then they did the puncture.
Okay.
They put anesthesia first.
So, so we do ours very similar. I cheat and I use a CT scan to help guide my needle to go, and a bone marrow biopsy will actually go in your iliac bone. So I tell people, when you put your hand on your hips, that's your iliac bone. So that's where we go in for the bone marrow biopsy. our techs would scan you, and I would find the area that looks like the best area for me to have a straight shot to go down. So then when you were on the table, do you remember some things that they did right at the beginning? Very, very important, before they even gave you local anesthetic.
She felt the area. She tried to find the area where she was going into, and she asked me which side I would want it on. What else did she do?
Something. Yeah.
Alcohol.
Yeah. Disinfecting it. Very, very important, because with any of the lines that we do or any biopsies, with any time that you break the skin, I always consent. There's for bleeding, infection, and injury to the tissue and surrounding structures. Infection is something that is really important because if you are breaking the skin and you have not sanitized the skin, you can cause more harm than good. So if I take a large bore needle and I didn't clean the skin off and then I put it in someone's bone, I could really cause a huge issue. So cleaning off the skin prior to doing a procedure is very, very important.
Right.
And so then after you do the procedure and you get your samples, what are some things that do you remember that they asked you to do after?
They put a plastic on it so that when I shower, or I don't think I showered that day actually, because I think she told me I couldn't, to prevent infection as well. And then to keep it sanitized, like I couldn't go to the pool or the beach or like have a bathtub or something, go in the bathtub or something like that.
Yes, that's perfect. And that's exactly what I tell people. No hot tubs, bathtubs, pools, showers are okay, but you don't want anybody soaking in dirty water when they have a sore, especially when you have a track where you made with a needle. So it's always important for that area to be healed and closed up before they're, sitting. And people are like, well, bathtub isn't dirty water, but it is. It's very different than just running water from a shower.
Right.
So that's really good. Yeah, that's fantastic. The fact that you had it is a little bit cheating, but
yeah, very true. It was very painful though, so I hope no one else has had that before.
Yeah, that's another perk to having it by us. When they do it in the office, they usually it's in an outpatient facility. Versus when we do it in the hospital, we sedate you or give you some type of medication to help make you comfortable, which is the beauty of being in a hospital. Additionally, when you have a bone marrow biopsy, just in this particular case, they are just doing it by feel. And so they go in, they see if they can, by feel, they see if they get anything. If they don't, then they go into a new location versus when I do it under CT guidance, I'm watching my needle the whole time. So I know that I'm in, I know that there's no going in and seeing. And then if it's not there, like I know that I'm there.
Right.
So that's really it. That was a quick one.
Awesome. I also had a question because I also had an IR biopsy like in my neck here.
Mm-hmm.
For that one, they used do you use an ultrasound for that one?
You do.
And you could see as well, like similarly to the bone marrow?
Exactly. So were you awake?
I was.
Okay. So most of the time you would be. In fact, I wouldn't. Very rarely would I sedate anybody to do a lymph node biopsy or a mass biopsy in their neck, unless they were talking or couldn't cooperate. But in general, most people can cooperate enough that you can tell them to be still because it's very quick. And basically what I'm doing is I'm actually looking at a screen just like I'm looking at you guys here. But I'm right-handed. So with my left hand, I use an ultrasound probe. And then with my right hand, this would be my needle. And I'm watching the screen, but I'm using these hands to do something else. So I'm actively watching my needle go into the mass or the lymph node, whatever the case may be. And that's the same thing that I'm doing with the CT scanner. So I'm looking at my CT, looks like TV screens. and I advance my needle, then I touch my CT scanner pedal, which is CT fluoro, and then it takes a picture, and I can actively watch my needle go down as I'm getting the sample. So those techniques are very similar, despite whether it's ultrasound, fluoroscopy, CT, all of that.
Oh, that's super cool.
Yeah.
Awesome. Do you have any other questions, Vanessa?
No, not really. That was awesome. I'm super.
Thank you. Thank you so much.
Thank you so much for having me.
No problem.
Thank you. It was nice to meet you.
Good
You
job.
too. Thank you.
Night. Okay, that was great. And we still have like over 150 people tuned in. So thank you so much, Angela.
Yeah, no problem. I was happy to do it.
This was great. I learned so much. I'm sure they all learned so much. It was interactive. You are amazing.
Oh, thank you. I appreciate it. Anytime. It was so much fun. Thank you.
Thank you so much. So I'm going to let you go, and I'm sure you have a ton of emails to answer.
It's okay. It's okay. I'll get to you guys.
Thank you. All right, guys. So see you guys next Monday. Thank you again, Angela. Have a good night.
Bye. Thank you, everyone. Have a great night.
Good night.